Hello, everyone. This is Mariah Muhammad with Becker's Healthcare. Thank you for joining us for today's webinar, Mayo Clinic Leaders on How Quality is a Catalyst for Better Margin, Outcomes, and Trust. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have issues with audio or visuals, just try refreshing your browser. You can also submit any technical questions into the Q&A box. We are always here to help. Today, we are joined by two quality leaders from Mayo Clinic, Dr. Pablo Moreno Franco, and Dr. Jennifer Cowart, who are going to share how they built a scalable process improvement system to drive margin, adopt AI and automation, improve outcomes, and maintain trust. Dr. Moreno Franco is a critical care physician and professor of medicine at Mayo Clinic in Florida, and Dr. Cowart is a hospitalist and associate professor of medicine at Mayo Clinic in Rochester. Together, they will walk through a sepsis case study that demonstrates how AI-enabled workflows and frontline engagement can continue to a system-wide model for improvement. Thank you both for joining us here today. I'll now turn the floor over to Dr. Moreno Franco to get us started.
Well, thank you so much for the kind introduction, and thank you all for being here today. With Dr. Cowart, we've been working on quality for many years. I led the quality committee for about 7 years. I've been leading the hospital practice in Florida now for the last year, and Dr. Cowart has been a strong partner in the development of our quality improvement system. So we wanted to share with you the different steps and processes that we've put in place. But we should start conceptually by saying that high reliability is not a cost center. It is really the operating engine that creates better margins and improves growth. And executives in healthcare, they don't really buy projects one by one. They want to invest in a repeatable improvement system that is going to decrease variation and waste, that is going to improve outcomes, that is going to help protect the margin. So we'll walk today to how we've developed that system. We've also talked about the role of AI in quality and vice versa. We'll give you a case study of how we apply some of this methodology, and ideally also discuss some of the concepts here that you can take with you as a repeatable roadmap that can be used externally. So first, we know that poor quality is a cost structure. It can increase your length of stay. It can increase your readmissions. There are penalties associated to that. And certainly the most important concern that is harm to our patients, but also the rework that it can cause with our staff. So that means that we must ensure that we are creating a high reliability system that is helping improve our outcomes, improve the experience of our patients and our staff, and also create a better financial strategy for the institution. We're all acutely aware of external forces that are putting pressure in healthcare. That could be pay for value transitions. It could be the shifts that have occurred from process measure to actual outcome measures. And all of that is changing also the consumer expectations from healthcare. Most importantly, I think we're all acutely aware of the gold rush that is happening with AI and technology coming into healthcare, and how much that competition between vendors creates different layers of complexity in terms of additional costs for the healthcare organizations. And the big concern, can we even trust some of these tools that are being offered to us as tools that will solve this or that problem? So to put that into context, we need to go back to the basics of the value equation. We need to think that we need to base our decisions in the healthcare outcomes that matter to our patients, that matter to our staff, that matter to our payers. And also we have to take into account the cost that we're incurring to deliver those outcomes. And as such, we'll ask you to think the following. What operational frictions are you having in your institution? How much time is it taking to launch projects? And once you launch, are you able to complete those projects? Is that completion with reasonable success? So this is why it's important to think that our organizations could be paying a high tax in terms of poor quality. And like we were saying, if quality is a financial strategy, the real question is what happens when it falls? So Jen, please take us there.
Absolutely. So in my previous roles in patient safety and quality, I saw this firsthand at the system level. Also, as a hospitalist, this is the world that I inhabit. So when we're talking about care in the hospital or care in the clinic or care in the OR, we're looking at the prices of readmissions. That may be directly due to penalties from payers. It may be reduced reimbursement. And also, we're exhausting some of our patients' insurance when they're trying to get to post-acute care. They're continually cycling through the hospital into the post-acute space. We're not being good financial stewards of their resources. Excess length of stay. If we're not prepared for a timely and safe and stable discharge, then we're going to be recouping cost and not getting that back in terms of getting patients safely and effectively out of the hospital. Staff burnout. This is maybe harder to appreciate and measure, but I can tell you that there's a world of difference in working with a seasoned and experienced team of nurses and care staff and clinicians versus new people having to come in all the time. There's tangible finite costs to re-onboarding people and filling those slots. And then we can measure that and we can actually look at what happens when we burn our people out instead of taking care of them. There's, of course, preventable mortality. We're here because we want to take good care of patients. If there are avoidable mortalities, if there's poor care being delivered, that's not only loss of life and loss of a loved one for that family, it's also direct costs to the institution. It might be litigation or other costs related. So we're always trying to avoid that. And then pilot purgatory of AI. Everybody is piloting all these AI agents and projects and algorithms everywhere, but some things just stay in pilot forever. We're not able to get them to the actual bedside to help clinicians. It seems like everybody has their shiny AI toy right now, and we need to be sure that we are piloting in a good time fashion to get things to the bedside and getting rid of the chaff so that we are only using those tools that are effective. On the flip side, though, we know that higher quality creates that value. When our patients have better outcomes and they have a better experience, they are more likely to recommend us. They're more likely to come back. They're more likely to view us as their healthcare provider of choice, and that produces sustainable growth. There are a lot of external organizations that measure this. We could look at patient satisfaction with HCAHPS. Of course, we have CMS stars, Leapfrog, US News War Report, Newsweek, all of those other rankings. They tend to do better and correlate when patients do better. And unfortunately, they also suffer when patients are not doing well. So we want to be sure that we are balancing those and making sure that our patients are choosing us because they know our quality is good. And we know that they will not choose us if our quality is not. I think we're both hitting the button there. Sorry. All right, I'll hit the button. So in looking at how we find this path forward, before I turn it back over to Pablo, we look at quality, reliability, trust, and growth so that we can really see how we build this model to continuously improve outcomes and strengthening our financial performance. A lot of these come from high reliability principles that you're probably very familiar with already. So preoccupation with failure, not because we want to fail or because we want to blame people, but because we want to look for zero harm and we want to address risk at that system level. We want to be highly reliable and sensitive to those operations of how do people, processes, and systems work together. In this digital era, a lot of the systems we're looking at are online, they're cloud-based, or they're your EHR. And if your EHR is not serving your patients or your providers, then you're going to have more quality, poor outcomes. deference to expertise, really not just from above and looking to those at the high end of the food chain, but really those at the front line. So we need to be always listening to our frontline clinicians, nursing staff, techs, the people who clean the rooms and turn them over. If we can't get our rooms clean, we can't get patients in, and we increase our length of stay, and we increase ED boarding. Every person's expertise matter, and we should be looking down the hierarchy at those frontline people who have that expertise. Finally, commitment to resilience and growth. So we're really looking to try to get complexities out where they don't need to be, but also making sure that we're not oversimplifying complex processes and looking at past events to learn. Therefore, we can improve in the future. And I think this is something that, Pablo, we've done really, really well in working together. So what does this operating model look like in practice?
Well, thank you, Jen. I think the key element of a successful operating scalable improvement model is the combination of having some centralized enablement, but also some decentralized ownership. And that's what we call the QI supercharger. The reality is that before you get to those two systems, you have to start with the people. You have to start with a clear purpose and vision, and that's what we focus on, a continuous learning for engineering advanced reliability. And it's also an opportunity to shape the future of a trustworthy human-centered healthcare system. And we do that through trying to simplify the whole system to 3 steps: understand, transform, and sustain. And we will talk a little bit more about a paper that we recently put out on this, and we'll get to each one of those layers. But these ideas become relevant when we get to the centralized quality and that quality supercharger, because it is our people who understand quality improvement methodology and who also get the data and understand the data. So we have different areas that feed data into our different platforms or different dashboards. And then we need to take into account the benchmarking with other institutions. We need to have our leaders take into account the internal and external risks and opportunities to really define what are the vital few priorities that we need to focus on. Once those priorities are defined, then our data and analytics team can help us do some correlation and aggregation of the data. Ultimately, we cannot solve all the problems. We have limited resources. So we have to pick some of those vital few. We have to define the size of those projects and who can work on them. And based on the size, we can resource them appropriately and then move toward the transformation and then eventually the sustainment phase. After that transformation, we're always tracking the outcomes. We're always tracking the data. And that data can be used for, let's say, external publications and showing other institutions what we're doing. But at the same time, all the data that is produced is being fed back to our committees, and it allows our leaders to continue to refine our priorities going forward. So this is, in a nutshell, that centralized aspect of the way we do quality. But Jen, we have also together worked on the decentralized aspect of quality. We've worked with the quality improvement champions. So can you tell us, how does that work in the organization when we're able to break down the silos and make both the centralized aspects and decentralized aspects work together?
Absolutely. Thank you, Pablo. So I would say the first thing, if I think of silos as vertical integration that don't communicate, I immediately think horizontal integration to try to break down those silos. So what you're seeing here is on the black line are a number of positions that are enterprise-wide. So these are across the Mayo Clinic organization. These are expert groups and chairs and committees that oversee patient safety, staff safety, data analytics, patient experience, and accreditation and regulation. There's a number of groups here. These all represent committees that have professional staff with quality leaders, as well as physician leaders who have time dedicated to this work. It's always a partial piece of their time, because we want people who are leaders to be also seeing patients, immersed in the practice, and then bringing their quality skills to the practice and their practice skills to quality. So what you're seeing here is a lot of investment and a lot of people who are involved, but on a part-time basis as far as the clinicians are concerned, with some full-time staff who are trained in assisting with those various topics. That is the enterprise level line. And then below that, you'll see the site level. So for the last couple of years, I represented Mayo Clinic Florida as the quality chair. I chaired the committee in Florida, and I represented Florida at the quality committee at the enterprise level. I also had my administrative partner who would assist me with that work. And so you can see there on that line, on the blue line at the bottom for site, we have safety, experience, accreditation, documentation, mortality review, connecting again at different levels. So what we're trying to show here is that across the enterprise, we want to break down those silos and connect people in network. And then at the site level, we're doing the same thing to really bring those down. We want to identify any pockets of excellence across the organization to bring those to awareness as quickly as we can, and then to share those best practices across the entire organization. We would then carefully also track our public reporting, including metrics, including HCAHPS and patient satisfaction, and then ultimately how that ties into value-based purchasing. So we could ensure that we were aware at that highest level, as well at the site level, of everything that was happening relating to quality. In 2019, we started to really look at platform thinking and how to scale this model. And we're going to talk later in this session about Mayo Clinic platform. But just so to be clear that we had started a lot of this work in the pre-AI era, and then continue this work and develop this work into the AI era. But now I want to bring a specific example of how we have used this, again, prior to the recent onset of AI use at the bedside and then moving forward. And that is going to be in mortality review. So as I said, we want to always be learning from events in the past and then applying those lessons into the future. So over the past several years, the enterprise has implemented new practices on mortality review. It starts with the clinicians, with quality champions identified by each area of the practice who review cases within their practice area. Those are then collated by a site level mortality review committee with a clinician chair as well as quality staff. And then they gather that data. They may require a formal M&M if there's a complex case. They also collate that data and send it into a more centralized system. What we're doing to really move this into 2026 and beyond. So this started as site level systems and databases. Now we have created a more centralized database where we can really start using more AI tools for synthesizing that data, summarizing that data, identifying what we call OFIs, opportunities for improvement. Maybe we had an opportunity for improvement at one site related to a device. Other sites may use that device as well. We need to share that information quickly so that we can improve safety across our organization that spans multiple states. So I think there's a lot of room here to talk about how the humans are looking at these cases and applying their clinical expertise to clinical cases, but then also using technology, AI, summarizing the charts, summarizing the findings so that we can better identify what is happening at the bedside. And then moving into those soft skills, maybe AI can take some of the data aggregation tools as topics off my plate so that I can use my soft skills in debriefing with my teams to reduce burnout after bad events or unexpected outcomes. I can be using that to connect with my patients at the bedside. So I always like to think of AI taking those tasks off of my plate so I can improve my soft skills and human connection. But Pablo, I think we wanted to talk now less conceptually and more proof, and start to get into even a few more examples.
Yeah, thank you so much. I would also highlight that as we move through some of these committees and groups that Jen mentioned, it's always important to have a triad leadership model. Our nursing staff, our administrative partners, our physician partners are always working together and helping each other to solve these problems. But then, we want to take you to the era of AI, as Jen was describing. So how does Mayo Clinic operationalize quality in workflow design? Why allowing technology and AI to enable some of the processes. We still need to utilize a very rigid change management of the rigor that brings. And we need to focus also on the sustainment and most importantly, the accountability of those tools. So we'll talk a little bit about how we do that and also how those platform comes into place. So we were mentioning to you, introducing the concept of the UTS framework. So if you scan the QR code, you'll see the recent paper that we put out in Mayo Clinic Proceedings for Quality, Innovation, and Outcomes. Because it is by utilizing these quality improvement tools that we can then better plan and implement AI implementation. So what does understand really entails? It entails understanding the clinical workflow really, really well. So that needs to be mapped. We need to understand which areas of that process could be automated or not. But it also means understanding the tool. Not every AI algorithm is created equal. We need to understand the data that it came from, the level of bias, or the level of missingness in that data. How were those issues treated or managed to improve the algorithm performance? Once we've done those things and we have data readiness and we do that transparently, we can then move to design and implement in the transform phase potential solutions that could be introduced into the workflows or the clinical practice. And to do that, we use agile methodology, we use plan to study act cycles, and like that. So we can eventually refine and test those interventions. Sometimes we need to go back to the drawing board and recognize maybe some inefficiencies or something incorrect in the algorithm and improve it. Sometimes it is successful after different tries. And once we have success in the implementation, then and only then we can move to the sustainment phase. That sustainment phase, it is really important to characterize who will own that process and that tool going forward. It's important to characterize that the accountability needs to be maintained. So we produce algorithms that not only feed our performance, but also we create dashboards that can be utilized to then help continuously transform the way we do our workflow, our process, or eventually be part of a continuous feedback learning healthcare system. So in terms of a particular example, we wanted to use sepsis. Why sepsis? Well, because it's a time-critical and multi-unit issue. It involves the emergency department, the inpatient units, the ICU, and it also has layers outside the clinical care. It has layers like abstraction and documentation that can make compliance really difficult to track. So imagine that you are a provider, and imagine that you get an alert that the patient in ED room 1 is septic and that you need to react to that. So do you actually trust that technology? Are you going to believe that the information that is given to you is appropriate? So this is where the concepts of trust become really relevant. So the providers need to not only trust the AI model, they need to trust the data in which the algorithm was trained. They need to be able to trust the team that deployed this tool. And to do that, it's important that many different steps are taken into account. So we'll walk you, for example, about how we did the implementation of the sepsis AI tool in our shop in Mayo Clinic, Florida. And first, we understood very well the workflow that the different practice teams took. But then we also spent the time understanding the tool that was going to be deployed. Once we did that, we had done some research regarding who would be the best teams to receive the alert, understanding that you need to have a specific group of individuals who are in charge of reviewing the alert and acknowledging the alert. So that could be either your rapid response teams or an EICU team, depending on your setup. But it is then that group of individuals who serve as the human in the loop and they would tap into the clinical practice and then let them know that this patient might be septic. So it actually worked really well when we looked at the data. There was more than 90% concordance when the clinical teams got the notification from the AI alert and the human in the loop. More than 90% of the time they agreed that, with the alert, and they went on to prescribe the necessary elements of the bundle. So once we understood and designed that, that's when we moved to the transform phase. And the transform phase really takes a lot of resilience, patience, a lot of collaboration, many plan do study act cycles until you eventually move to a point that your nursing teams, your ordering providers have buy-in into the tool, and only then you can move on to use the workflow in different areas, not only of the same institution, but you can move to other sides of the enterprise. So in the sustainment phase, as you move to other areas, or as you move to the sustainment phase, it is critically important to identify who were the individuals that helped deploy that tool. And that's what we usually call a team card. So usually you have a model card that explains the model, how it was deployed, and you have a team card to see who were the individuals that deployed the tool. We can understand their positionality, the assumptions that they took, what key choices or decisions were made, how was bias mitigated. So all of that really allows for a more cohesive message to the clinical practice. And we were very happy to see that for the first time, our sepsis SEP1 bundle compliance went above 80%. And we were also very happy to see that it correlated with a further decrease in the observed or expected sepsis mortality. As you know, less than 1 is better. We were able to get close to 0.78. So all these signifies that the teams are utilizing the tool, that they're responding to it, and that they're able to influence not only the process outcomes of SEP1 bundle compliance, but also the most important outcome, which is the patient outcome associated to that. So at this point, you would stop and think, well, that's working for Mayo. So how do we take such a repeatable roadmap and apply it not only in other areas of Mayo, but in other institutions? And I think you can all think that there's a fast kind of a push for healthcare to be interoperable and to have automated data extraction, curation, and auditing. So all of that requires cooperation among different organizations. But for us, it continues to be central to apply human intelligence and to use the understand, transform, sustain framework as a catalyst to help responsible innovation and responsible diffusion. It is true, as Jen mentioned, that AI is a massive accelerator. There are many things that is going to help us do better with the appropriate human oversight, so that every patient that goes through the system, every interaction, becomes indeed a valuable learned lesson that allows our continuous improvement for high reliability journey to continue. So we also wanted to reflect with you that AI is not static. We all know that the algorithms may drift or may shift. And in that regard, it is very, very important in that sustainment phase to have AI implementation controls, to have feedback loops post-deployment that allow for human override in certain cases, and continue to evaluate for potential bias or potential shifts or drifts that may occur in the deployment of the tools. So before we talk more about how could your organization adopt this framework, we wanted to pause and take a minute to think about a quote from our past, the Mayo Clinic past, that highlights how our founders rooted themselves in teamwork and collaboration. So Dr. Mayo once said that in order to help the sick, a union of forces is necessary. And it is part of the reason that we're honored to be with you on this webinar today, because it is part of the foundational mission of Mayo Clinic to allow those things that we're learning as a healthcare organization and share it outside of the four walls of our institution so that others can take advantage of these ideas in quality improvement journeys and technology implementation to help patients everywhere. And in the recent years, the mission at Mayo Clinic has been fulfilled by something that we call Mayo Clinic Platform, which is a comprehensive ecosystem that brings together, in one hand, data partners who are helping us build the foundation of the platform. It also brings AI solution developers, so they are either training or validating algorithms utilizing this data. But most importantly, it brings a community of other healthcare organizations across the world who are part of the ecosystem that have gained access to Mayo Clinic's knowledge and expertise. And all of that can be diffused and transferred to other institutions that participate in the platform. So when we stop and think about the pressures that we discussed at the beginning of the webinar, we also have to think that, in a way, Mayo Clinic is building a solution to help other organizations overcome some of these barriers. So the Mayo Clinic platform deployment capabilities can help you integrate with other workflows. There are teams of experts who can help provide guidance in terms of support, depending on the area of focus of your organization. But most importantly, in this noisy marketplace of so many AI technology solutions, in that digital gold rush that we talked about at the beginning, the ability to run your algorithms in the platform, to test them really well before they are deployed, that makes it easy to adapt solutions in a way that can be trusted by our clinical team. And it is that credibility that can make the whole difference between a successful implementation or not. In a sense, we have seen the result of these collaborations to show by itself how successful those institutions can be. And in the resources for this webinar, you can see information about the Mayo Clinic platform. You can see information about some of the organizations in terms of case studies that we have collaborated with, and how you can achieve some of these measurable results in your institution. So if you want to learn more, we definitely invite you to click in those resources and take a look at what could be applied. So in closing today, we want to reflect with you that at the institutional level, it's important to build coalitions, to have a centralized group who is managing your quality efforts, but also to have that decentralized quality in terms of quality improvement, champions, and the triads in the different departments, divisions, or units that are helping improve the performance. But most importantly, we need to be very, very mindful regarding process improvement before AI implementation. And that's where we invite you to study the Understand, Transform, and Sustain framework, to think about how you could use those tools to create more trust and a more clear deployment pathway in your institution. We definitely believe that quality is even more important now in the era of AI. We know that to have reliable delivery, in a patient-centric way, we also have to be able to match or meet, their compliance regulations in terms of transparency and deployment. We invite you to create model cards and team cards that could be shown to the different teams as the AI tools are being deployed. But most importantly, we have a very important role to educate the new generation of healthcare providers healthcare administrators to be able to continue to use these process improvement tools that have been proven over the years as we apply new technologies. We can leverage that knowledge in terms of quality curriculum, agentic AI, and if we do that appropriately, we certainly believe that AI can be an accelerator to help us transform real-world evidence into better knowledge and better care for our patients. So with that, we will close the formal presentation from Dr. Cowart and myself, and we're more than happy to take the questions that you all may have. Thank you.
Wonderful. Thank you both for a wonderful discussion. As stated, we will now begin today's question and answer session. Audience, please, again, feel free to submit your questions via the Q&A box you see on your screen. So let's just get started. So the first question I have from the audience is, I'm curious how your bedside caregivers are adopting AI, and if you're doing any proactive education on what it is not, and how we can reinforce the human input and review of AI. I really appreciate the presentation.
Jen, do you want to start?
We could both take that one. Yeah. So I think this is a really great question. Thank you, Patty. As a hospitalist, I have started using AI in a few different ways in my clinical practice. First, we adopted a few AI tools within our EHR, one being an AI summarizing tool to assist with the creation of the discharge summary. There's research out there that shows that a timely discharge summary may be correlated with reduced risk of readmission, and certainly the converse seems to be true. If your discharge summary is delayed, patient may be more likely to readmit. And writing discharge summaries is bulky and cumbersome. So we have adopted an AI tool there. We refine it constantly. We have a feedback mechanism within the tools so that a provider can give a thumbs up or thumbs down with any comments that they wish, and teams that evaluate that tool. But we do have research comparing it to human-generated discharge summaries and finding that the quality is similar, if not better, in some circumstances. But we have language that it's only for draft. It must be reviewed by a human clinician. It does not auto-populate into the discharge summary. You have to actually move it there yourself, and that's stickiness that we built in on purpose. The other thing that I would say I'm doing on the regular now is reviewing a lot more of my cases diagnostically in AI tools, such as Open Evidence or similar. I do a lot of diagnostic questioning with the programs. I do a lot of teeing up of templates and prompts. I do not ever use HIPAA protected information when I put it into those tools. I only ever use de-identified information. I never put anything that would be protected in there. But I've generated diagnostic lists. I have generated patient-facing instructions that I always verify are accurate before I hand to the patient. Those are just a few ways that I'm using it in inpatient. And I know in outpatient, we're using a lot more AI scribing technology to assist with clinician writing notes, to make those go faster, but also be more accurate. So we're trying to improve patient safety as well as provider satisfaction, reduce burnout in those ways. Pablo, how are you and your teams in the ICU using AI?
Yeah, I would take maybe even a larger perspective, and it's that we are trying to educate our workforce in terms of AI tools. It's important to recognize that a lot of this technology, it's new to the majority of our healthcare providers. So in that regard, we've organized different meetings and sessions that work longitudinally in terms of journal clubs or data conferences. But most importantly, I would highlight two things. Number one, for the past couple of years, we've done a conference called a Datathon, where you bring data scientists, clinicians to the same table. You ask critical questions that are related to patient outcomes, and we look at different data sets, and we ask them to actually work together to figure out algorithms or ways to solve those questions using the data. So it's a great learning opportunity for healthcare providers. The second example, we're just embarking on that this year, it's for the first time we're doing an agenthon. So that means we have invited individuals who are interested in agentic AI to participate in a longitudinal training for agentic AI. And then we're starting to get together at the different sites with trainers so we can teach our individuals how they could maybe use some of these agents to help them solve either operational problems or ideally, also educational research and one day clinical problems as well.
Wonderful. Thank you both for answering that question. And then, Dr. This is another question for you, Dr. Moreno. I've seen participated in some quality improvement initiatives that start strong, but ultimately struggle to produce lasting results. When you're leading a new improvement initiative, is there a structured approach, blueprint, or roadmap that you use to maximize the chances of long-term success?
That is an excellent question, and I wish
I knew you would like that one.
Yeah, I wish there was an easy formula. I think the reality is this is where change management actually becomes a key element for implementation science or quality improvement. Because change management also takes into account not only who is executing the change, but who is responsible, who is accountable, who is sponsoring the change. You see, there's other structures within the organization that may be either part of the barriers or part of the solution. And it is part of the sponsors of those projects' ability to be able to understand where are the barriers and how they can remove those barriers or remove the friction so that the projects and the teams can move forward. Historically, we also see our mission as one to educate our trainees on how to do these projects. And for many years, we've organized what we call a flipped classroom method, in which we teach healthcare providers, multidisciplinary team members, nurses, advanced practice providers, respiratory therapists, and healthcare administrators as well. So we've taught them what tools to use, when to use them, and most importantly, the flipped classroom means that they actually come to the classes with problems. What are they trying to solve? What barriers they're facing? And it is in that friction that most of the learning actually occurs.
I think I would add to that really excellent answer. Part of sustaining a quality improvement initiative means picking really good problems to solve and really good interventions in the first place with appropriate governance structures who can monitor it afterwards. One thing that I sometimes see is that people will start with an intervention in mind rather than what is the problem we're trying to solve and the data that shows it's a problem. So if I have a flyer and I just want to hand out a flyer and that's my own intervention, I don't know if I'm actually solving a problem or not. And it may not sustain because I may not have identified the problem correctly. So I do think that the training that we do in quality for our staff here at Mayo Clinic and at other organizations should really focus on pick a really good problem in the first place with actionable data. Make sure that your solution is actually going to solve the problem that you think it will be. Hardwire it as much as possible, and then make sure that you've planned a governance structure for monitoring after.
Perfect. Thank you so much. And then I wanted to ask, I guess going more into the data, unless you kind of answered already, healthcare organizations collect an enormous amount of data. How do you decide which metrics truly deserve leadership's attention and which are just noise?
I can maybe start this one and then tee it to Pablo. Sorry to be to talk over you. One of the ways that when I was the quality chair, I showed you that slide with the horizontal leadership structures. And so there's a lot of committees with a lot of expertise. So there ends up being a lot of committee consensus. But the data that we would bring to those committees to pick metrics to view would really include what's important to our CMS and our payers, what's important for value-based purchasing, what's important for external facing reporting and rankings, either public reporting or rankings. And then we would come up with groups of metrics that we thought were most appropriate at different levels. So we had a core group of metrics and a scorecard that we would show for board members, for example, CEO, C-suite type levels. Then we would have a level of details that we would release for our site level leaders. And then we would have additional levels of detail that we would roll out in scorecards to others. It was all available for anybody to see, but in terms of delivering that data, we would really pick what we thought was actionable, and then we would tweak it. We never thought, oh, this is the scorecard, it's going to look like this forever and ever. We knew it was going to have to be monitored over time, but we would do the best we could to try to balance getting it out with timely with having the right measures. Pablo?
Completely agree with you, Jen. And I will also bring the example of our heat map that we actually discussed in our hospital operations meeting. Just this morning, we were in our hospital operations meeting for Mayo Clinic, Florida. It's a meeting in which quality, safety, experience, IPAC, all these different groups that Jen mentioned are working together with hospital practice leadership. So we're sitting there and essentially with a very deliberate and fast approach, focusing on which areas do we find heat on. So, 1 month it'll be your falls, next month maybe CLABSI, next month maybe patient experience. So it varies, and where the organizational focus should move in the next few months is going to depend on those metrics. Now, ideally, you have to have a very deliberate design to which metrics you're going to be tracking, because we cannot track it all, right? If you take into account US News, CMS star rating, HCAHPS, etc., leapfrog, all of a sudden you have 300, 400 things. So not all of that could be tracked. So there are ways that we've applied to, do data analysis and kind of simplify the vital few that we should be focusing on. And then it is with that way that we can allow our committees, our units to really manage how much change is happening at each level.
Wonderful. Perfect. Thank you so much for answering that. Audience, again, please feel free to submit any questions you have. We have a little bit of time. Dr. Cowart, if I can go to you, how are you sustaining reliability while preventing alert fatigue or noise?
Yeah, I think that's a great question. So, one of my current leadership roles is actually looking at new solutions for our electronic health record. We are very active in managing our EHR, both what we implement that comes from the EHR vendor, as well as what we may innovate and create locally. So, we're always looking for how can we fix big problems and how can we fix pebbles in the shoe. I really love to try to take little things that are driving people crazy and try to fix it in the EHR. So when I'm looking at alert fatigue and noise, I want to be thinking two things. One is any new project coming into the EHR. We need to be really thoughtful about that alarm fatigue. If it's a pop-up alert, does it need to be a pop-up alert? Is that appropriate? So we're very thoughtful and intentional about reviewing the new items coming in. Second is that in the EHR, we need to also be looking at previous alerts. Maybe it served our needs 5 or 6 years ago, but perhaps it's no longer as appropriate. Now that's just an EHR example, but I think that intentional viewpoint should also be applied to other technologies. IV pumps, for example, nurse call systems, trying to integrate your nurse call system with patient satisfaction tools, with patients being able to see their records, communicate with their provider teams, trying to streamline those so that people aren't getting one alert from that system and another alert from that system and another alert from that system. So I would say above all, intentionality and thinking about it. And then taking the feedback from your frontline clinicians and staff who are bothered by alert fatigue and noise, and then trying to reduce those issues for them in the future.
Wonderful. Thank you for answering that. And then Dr. Moreno, if I can go to you, how do you scale improvement when centralized QI resources are limited?
Well, that is indeed a critical factor, and it's a real one, right? I think, especially now, we're trying to implement more projects and more technology with less system engineers, with less quality improvement advisors. So that means we have to upskill the rest of our workforce. Every administrator, every nurse leader, administrator, every physician leader needs to know the basic tools of how to execute quality improvement, how to do change management. So in that regard, we go back to understand, transform, and sustain as an umbrella. You can, take different methodologies, the make, PDSA, lean, many of those things that we've learned over the years, key quality tools, and those individuals need to be able to pull out the specific tool that they need at that specific time. For that, you need a deliberate quality improvement education system. And that is something that for 20 years we've had at Mayo Clinic called the Quality Academy. And it's been the place where we train individuals to be able to apply these tools doing real-time projects. So ultimately, there's always going to be resource limitations. There also needs to be some degree of prioritization. And this is where sometimes it's difficult to make decisions as leaders of the institution. Sometimes there are things that would be good to have, but we don't have the resources to apply it. So you go back and you focus on those things that are more important. We often use impact effort prioritization grids to make decisions on which projects should go and which projects should stay in the parking lot.
Perfect. Thank you so much for answering that. Another audience question that came in, many healthcare organizations don't have the same, sorry, I was reading another one. As healthcare becomes increasingly AI enabled, how do you see the role of traditional quality improvement methods standing the test of time or evolving over the next decade? Dr. Moreno, do you want to answer that first?
Yeah, I'm happy to. I think many leaders, many institutions may feel tempted to kind of repurpose their employees or their quality improvement resources to do some of the technology implementation aspects. And to some extent, that may be okay because we want those individuals that know quality to be able to get outside of the typical methodology and comfort zone and apply the new tools. There are some individuals that we know in the institution, for example, who have been very successful at moving across the space of quality to AI, and they're actually embracing that methodology, and they're also embracing agentic AI. So I think the question is really, how do we upskill our workforce so that they can be the workforce of the future, so that they can learn this new methodology and still be true to the things that have proven successful over the years.
Perfect. And then another question that came in, how are you maintaining patient trust when implementing AI?
I think that's for both of us, maybe, or I'll jump in and start. So for me, I think, what is a task that AI can and should do? What is a task that a computer can and should do? And what is a task that humans can and should do? So I believe that what makes me a good clinician and doctor is the time I spend at the bedside talking to patients, trying to decide what's wrong with them, what am I going to do about it, and then connecting with them on a deep level. So the more that I can use AI to help me come up with diagnosis, differential diagnosis primarily, not the only one, the more I can do that, and spend more time at the bedside, I think what our patients want is to trust us as an organization, and we as clinicians, doctors, providers, we are the face of that. So my thought, first off, is that rather than just asking them to trust AI, that we want them to trust us. And we may use AI tools, but we are trustworthy. So we build trust by being trustworthy. I think if we make errors, whether it's an AI error or a human error, we would still do our usual process of disclosure, apology, making sure that we've done the right things. So, in my mind, the frameworks of quality and patient safety from years past are not any different in that regard. But I do think that as we're looking at how our patients will trust us in this era of AI, we should really think closely about how are we using it? Are we using it as patient facing? Are we making sure that we're building soft skills in all of our staff, whether they're frontline nursing, whether they're the people who clean the rooms, the people who check them out at the cafeteria, take their to the surgeon who does the big surgery, whatever and whomever they are we working on the soft skills? Because that's where the more we offload computer stuff to computers, we're left with soft skills and connecting at the bedside. So for me, it's less about are they trusting AI, but are they trusting us, and are we being trustworthy to engender that trust? Pablo, I know you think about this a lot too.
I do, and I think I'll go back to two concepts. Number one is that is indeed why we've talked about and published regarding the UTS framework, because in that sustainment phase, you need to have clear accountability. Who owns this tool and who is tracking that tool? And the second concept is Mayo Clinic has been at the forefront of AI implementation in healthcare. That was a very deliberate decision by our CEO back in 2018, 2019 to say, first, we're going to decentralize AI at the institution so that many departments can develop their own algorithms, but also a very concentrated decision to then say, we also are going to have a centralized way to manage AI tool implementation. And in that regard, there is a group that is in charge of monitoring every AI deployment across the institution. And it's through the combination of both that I think we can say that people come to Mayo Clinic, they trust Mayo, but then Mayo Clinic needs to be able to demonstrate that there is accountability throughout the institution, there's accountability throughout the implementation of this technology. Using the example that Jen gave, if you do a procedure and let's say it's a wrong side procedure, it's a wrong procedure, that individual is accountable for the outcome. Similarly, if somebody implements an AI tool that has unintended consequences, there needs to be accountability on that, and there needs to be a way to fix it. So it is very important to understand how many AI tools have been deployed, who is in charge of monitoring that, and who is accountable.
Perfect. And then for the final question, since we're limited on time, another audience question. Dr. Moreno, maybe you can take us home. Many healthcare organizations don't have the same resources, data infrastructure, or dedicated quality teams as institutions like Mayo Clinic. For those just beginning their quality improvement journey, what would you recommend as the best place to start?
I think the best place to start is to get the tools right. So, get your frontline staff to speak the basics of quality improvement language. And there's plenty of resources from Institute of Healthcare Improvement, from Joint Commission and others. But it's also about equipping the leaders of the organization to be able to give people the time to apply these tools. Sometimes we're trying to move really, really fast for different pressures to implement things without necessarily stopping to do the appropriate mapping of the process or the appropriate understanding of the tool. So really encouraging our healthcare leaders, our financial office to say, hey, it is an investment, right? We started this talk talking about the investment on quality, the investment on being a high reliability organization, and why that pays off. And I think hopefully we've demonstrated through the presentation and the conversation that it is by executing these steps how we create trust, how we create safety, better outcomes, and most importantly, high reliability in our institutions. So with that, we'll thank everybody for their attention. I also want to thank deeply Dr. Cowart, who's been our partner in crime over the years. and we look forward to many, many more years of partnership. Thank you.
Wonderful. That is all the time we did have for today. So I do want to thank you both again for an excellent presentation, as well as Mayo Clinic platform for sponsoring today's webinar. Thank you again for joining us, and we hope you have a wonderful rest of your day.